Hello, everybody, and welcome to the webinar this evening, sponsored by Eaglet Eye. And the title of the webinar is the Eye Surface Profiler, Transforming Specialty Contact Lens Fitting. And many of you probably are familiar with the Eye Surface Profiler as being something for scleral lenses, but it's not anymore. If you've kept track of us, you've seen that we've added first lens fit algorithms for many different kinds of lenses, and it's a device that really serves the entire contact lens spectrum. And a little bit of housekeeping tonight. If you have a question, because we've got a terrific speaker I'm going to introduce in just a second. By the way, my name is Ted Newell, and I'm the U.S. Business Development Manager. And in the background, we have Elena Barrios. She is our head of marketing. She's up in the wee hours of 2:30 in the morning over in the Netherlands, helping us out. And if you do have something like a question, you can put it in the chat. If it's a question that is fairly basic that Elena can answer, maybe something about the company, she will probably answer it right away. Otherwise, we'll hold it to the end of the program and we will have our speaker take care of the questions at that time. So I'd like to introduce Dr. Sheila Morrison, and many of you already know Sheila from listening to her make presentations at many meetings all around the world. She earned her Doctor of Optometry and completed a master's degree in vision science at the Pacific University College of Optometry. She served on on the faculty of the University of Houston College of Optometry, where she facilitated education and research in the contact lens and cornea service. Now, currently, Dr. Morrison practices at Mission Eye Care Center in Calgary, Canada, where she is the co-residency supervisor. And she's also an adjunct faculty at the NSU Oklahoma College of Optometry in Tahlequah, Oklahoma. A beautiful little town. So with that, I'm going to turn this over to Sheila because you don't want to listen to me talk. She's got a great program that will really go into a lot of detail about the eye surface profiler, which is a corneo-scleral profilometer, and some case studies. So Sheila, it's all yours.
Well, thanks so much for having me. It's always a pleasure. I do appreciate these times to actually pull together cases and work with the folks at Eaglet. They don't pay me to say this in any way, shape, or form, but I've genuinely, over the last decade, had an absolute blast working with the team. So my background in using the ESP specifically starts off as a very early beta tester. So when I was doing my residency at Pacific University, we started working with the company doing beta testing using the unit. And I have to say it's come a very, very long way. In the beginning, there weren't the same algorithms, which I'm going to share with you about them, and all of the, bells and whistles that the current modern day ESP that's actually such a useful, effective tool. Things have really changed. And, I want to go through some of the capabilities of the unit, how we use it in our clinic, and really kind of just share how it really is kind of a power tool for specialty lens fitters. It's very efficient and effective, and it is a cornerstone of our office. Now, profilometry-driven specialty lens fitting, is not just for the irregular eye anymore. In fact, it's one of the tools that we use as kind of a mainstay. I love this slide because it really, every eye has its own unique fingerprint, and you don't need an eye that is, a very difficult shape to be useful to use profilometry. Today, empirical lens design is very analogous, using, if we think back to early corneal GP fitting, or the time before my time, when corneal topography was really a novel tool to have in the clinic. Today, empirical lens design is really based on accurate ocular surface measurements of the entire eye. And this is something that, is, again, analogous across all specialty lens designs. It's not just for sclerals, not just for corneal GPs, but we see today that profilometry really brings a whole element of precision to the device, or to our fitting styles today. But first of all, I want to talk just a little bit about, why do we need data? I want to give a little bit of information about more complete corneal data is useful and advantageous in the specialty lens clinic. Some of the things that, we see when using, profilometry for measuring ocular surface is that the data that we can generate is not just kind of a central portion. I want to show you a case in a few slides here, just highlighting how kind of broad the data is that we can get using profilometry today. Some of the things that we know from conventional corneal topography, we know that our central Ks are really not a great indicator for what the entire shape of the cornea looks like. And that is why corneal topography using elevation data across that entire surface, like you see on the right-hand side, can be a huge advantage when we're fitting really any lens modality, lenses that rest on the cornea and also those that vault over, like a scleral lens, because we really have to understand, the entire ocular shape. Some of the cool things about profilometry and using the ESP include also we're getting a real sag data. So we're with reflection-based systems, like we're using, I'll explain how the unit works. We're getting a full, real elevation-driven kind of image based on a best fit sphere that is not extrapolated. The data that we get from the unit covers, the full cornea, all the way out to the limbus and out onto the sclera as well. Some of the things that are really great also include the measuring does not fall victim to eyelashes getting in the way, unless the tissue is actually in the way, and I'll show you some examples of that a little bit later. But with the ESP, it's kind of nice because there's really no shadow from the nose or eyelashes, which is a little different from more of a commercially or conventional corneal topographer. Now, data has come a really long way as well. So when we look back at where we started with scleral lens fitting, for example, because a lot of us, when we think about profilometry and complete measurements of the ocular surface, when we look at maps like you see in this picture, scleral shape, we're thinking, scleral lenses only. I want to go through some cases in this seminar just to show that sclerals are not the only type of lens that we use profilometry data to fit. But I do want to talk a little bit about the scleral shape studies because they've really kind of generated a lot of information that tells us a lot of information about what we need to be choosing for a starting lens. Now, specialty lenses are not a one kind of size fits all. When it comes to evaluating ocular shape, no two fingerprints, just like our fingerprints, no two eyes are the same. In fact, it's not uncommon to have a patient that we measure in the clinic, looking at the right and left eye and finding that we have differences, that are sometimes significant, especially in eyes with pathology like keratoconus and other kinds of conditions like that. The reality is that where we started off fitting scleral lenses that were largely spherical, as time has gone on through study, looking at data driven from taking measurements like what you see on this screen, we have found that eyes are not the same right and left. In fact, most eyes are more asymmetric than symmetric. And you can see this is a figure from the SSSG study group, which is a group that has published several different articles looking at, shape of the eye. And we found that quadrant specific covers about 40.7% of patients, but irregular corneal shape and scleral shape also has a very large presence. Now, profilometry really allows us to dig a little bit deeper to get kind of a better picture. So again, I just want to highlight we have the ability to measure full ocular surface topography. We're using real data with no extrapolation. And also we have objective data and figures to really know what we're dealing with. So when it comes to choosing a lens design, whether it's a scleral lens, corneal lens, et cetera, profilometry is really a technology that allows us to efficiently fit because we measure first before we decide what kind of a lens design we're going to use. Now, our eye surface profiler, let's kind of get started and dig in a little bit here. I want to explain first a little bit about how the technology works. The unit's here on the right-hand side. Left is a screen that you'd see commonly with the software on it. We're going to dive in just a little bit closer to take a peek first at kind of explain the technology behind the ESP. Now, the ESP technology is based on Fourier transform profilometry. So it allows us to image the cornea and also the sclera. We use fluorescein that is put on the anterior surface of the eye, and I'll show you a video in a second here of exactly how it works. And the way that the unit works is that we have a photo that has a camera with 2 light projectors that come from different angles, and fast measurements are taken to reflect light off of a fluorescein kind of tear film and get elevation data from the measurements. The time that it takes to take measurements is about 3 minutes total. And I'll show you just a little bit more about how the measurements work next. Now, our eye surface profiler, just to kind of highlight again that there's really no hole in the data. When we take measurements, there's kind of an equal density across the whole anterior surface of the eye. So everywhere that there's fluorescein that's exposed with the lids moved out of the way is where we'll get data. So on your left-hand side shows kind of a raw eye image. There's fluorescein on this eye, and the lines across it kind of show kind of where the light is reflecting. And the output is on the right-hand side, giving an elevation map, again, based on best fit sphere of the sclera and then a second one of the cornea to give us exact, accurate elevation sort of heights of an eye. And the reason that elevation is so important when we fit specialty lenses, especially scleral or corneal, really anything, is that, you know, elevation more so than kind of corneal curvature, so power, elevation is really kind of the basis and the bones of exactly, you know, the structure that we're building a lens to fit on top of. And so by looking at elevation to decide sort of what are we dealing with of the eye shape, what are we dealing with, you know, what type of lens would be the best fit, elevation really gives us a very clear picture of exactly kind of what is going to be the first point on the eye for a piece of plastic or contact lens to come into contact with. Now, the way that the process works is we really act to streamline the data, and I want to kind of walk you through the complete fitting process of how we go from data acquisition into lenses that go through our labs. First of all, number one is we take the scan. So that's first and foremost. Number two, we analyze eye data. So there are several different maps, actually more than several. There's different maps and views, which I'll share some of them with you in the coming slides with some cases that allow us to really take a look at our scan and find out what that shape is, find out if our scan was high quality and so forth. The third step is really to use first lens fit algorithms that we use to calculate a lens. We can use the data that we generate to send straight to a lab to have them do the calculation for us, or within software, which I'll kind of talk a little bit more about, we can do the design ourselves. So there are fitters out there, myself included, depending on the day. Sometimes in the clinic when it gets really, really busy, you know, the last thing, if there's 10 orders sitting on our desk that we have time to do is go ahead into software and design every curve and everything on our own. Some days we want to do that. Some days we actually like to have consultants available to us with a simple click to be able to pick up and, you know, either design a lens from scratch or help to make modifications depending on kind of what you need. And so the way that the software works in the lens ordering systems, it can be really, you know, as involved or as much or as little as a practitioner wants. So take the scan, look at the data yourself. In our clinic, what we actually do is we'll take the scan and I look at it, number one, in the clinic to figure out what kind of a starting lens might be appropriate to determine power. When we design lenses empirically using profilometry like the ESP, using the technology does not take the place in most cases of putting a diagnostic lens on the eye to determine power, especially on irregular eyes. And so we'll use first kind of analysis of the data to pull a starting lens and use that data to easily and quickly get lenses on the eye in the clinic without a whole lot of effort on my half. To be honest, when I have patients in the clinic, I will spend the most of my time, especially in the beginning, talking about their goals, kind of figuring out what they're needing and doing sort of the higher level processing and thinking, because my staff are trained to take the data, know how to use a first lens fit. I've already given them instructions on a lens that I'm interested in using, and they'll pull starting lenses from stock even before I have to go and spend my time doing that. Now, when we take a scan, this is where we'll kind of slow things down just a little bit. So the scan process requires several key steps. And the key to success really is that operators really have to kind of remain focused on the guidelines of how to take measurements. So I kind of think of this like, follow the fitting guide. When we fit multifocal contact lenses, the number one thing that can cause us to go astray and have a poor quality result is if we go rogue and do things outside of what the manufacturer suggests for fitting a lens. And so when we take scans, it's very important that we kind of follow the steps precisely and do the same every single time. In our clinic, we've spent time, actually, we redo this every 6 months now with our staff and train staff on these fitting protocols so that we can make sure that the results are very accurate and also very consistent. And you'll find in the clinic, if you either, have your staff taking these measurements, or in the beginning, if you're taking the measurements yourself, we always have to circle back to make sure that we're following the appropriate protocols. And I'll just share with you just a little bit about kind of what that is. Now, the first step is to lubricate the eye. So we'll go ahead, and in the left-hand side, you can see we have a patient. Our staff usually lay everything out kind of in a row. So lubricating drops, fluorescein, everything that's needed. And first off, lubricate the eye with usually a preserve-free drop that's maybe a little bit more viscous, than saline, just to make sure that surface is very hydrated. Now, the next step is to pre-align the device. And so what we do is we place the patient, as you see on the right-hand side, into the instrument and get that chin rest set in the right spot, get everything lined up so that we're ready to go, and that we're ready to take great measurements. And then we lock it. So put it in place, get it all set up, lock the instrument. And then the next step is to instill the fluorescein. So unit is ready to go. Eye has already been hydrated. And you can see that the patient here in this case is having fluorescein instilled on the anterior surface of the eye. Usually what we do is we'll put a little bit of fluorescein on the top and bottom, and we go ahead and have them roll their eye up, down, left, and right. Make sure that it's nice and full of fluorescein. Lights are dimmed, and unit is already set up appropriately. Forward into the chin rest, and you can see on the right-hand side, and I may replay this video one more time for you, just to kind of show you how well, it's almost too quick. It's so quick that I can't really explain it fast enough. But basically, patient is forward, and we often will have a patient pull the lower lid down, where the technician or myself will pull the upper lid for them. And with the instrument, as we move in this picture, you can see that there are 2 white dots that are vertical, and then 2 small ones that are horizontal. And we line up the instrument so the horizontal is up and down, straight, vertical, above and below, and the horizontal is horizontal, and that allows us to have really great data. So open both eyelids, click, 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 done. We usually take like 3 images per eye at the time, and give them a little blink in between. And then you can go and check to see if the data had high quality, low quality, and so forth, to make sure that everything is looking really good. Now, the quality indicators are pretty awesome. So whenever our staff will take a measurement, we always have them go back into the indices that you see on the top. So when we're reviewing the scan, there's new features in the ESP that were not here a year ago, actually a year and a half ago, that have helped a lot in our clinic to make sure that the data that we're collecting is very high quality. So you can see we're looking at focus, centration, and coverage. Now, these indices, it is automatic that the unit will calculate it, so that it will kind of let our staff know if we need to redo it, or if it's high enough quality to be used. The other thing that we're really cognizant of in the clinic for high quality acquisition is to get the lids out of the way enough that we have enough real estate. So that involves taking the eyelids and pulling straight up, not to the side, and straight down, not to the side, because that will allow for a nice even opening. Another little tip and trick that I'll give when we're getting the patient aligned, you can pull the forehead back, or pull the chin back to kind of rotate the eye and give a little bit more real estate. If, say, they have really deep set eyes on the top, if you roll back and have them, or roll forward or backwards, depending on where there could be an eyelid cutting off the data, that will help a lot to get the lids out of the way really cleanly. Now, step 2 is analysis. So this is where things start to get really fun. This is where you can use the data to really speed things up in the clinic. And I want to share with you just a little bit about what the maps look like and give you some examples. Now, this first map that I'll show you is a map of the raw height data. So, for the human eye, you really don't see a lot of detail on such a map, but all the parameters in first lens algorithms are using this raw absolute height data. And so this can be, extremely useful when looking at, again, like I said, if we're considering, what points of an eye are going to be the first points of contact for any modality of lens. If I'm thinking about fitting, a scleral lens that has a broad optic zone with kind of a prolate shape, on the elevation map and the height map, we can really, predetermine and look at what is the sagittal height of a lens that we're going to need. Are there any hot spots where an eye is elevated with a pinguecula or something like that, that a lens is likely to bonk into it? And it really is useful in, number one, analyzing so that we understand what we're dealing with to be able to make the best decisions for a lens modality in the first place. But also, if we were going to, use first fit algorithms, the height map is accurate in allowing us to design a lens that will most accurately fit right on top of it with the fitting characteristics that we want. Now, this is an example of another map that we use, and in fact, this is one that I tend to pull first. It's called the bisphere elevation map. Now, to be able to see the sufficient data for analysis, we have the elevation map here, and this software calculates a best fitted sphere, and then the data that you see is kind of, plus or minus a best fit. So the colors that you see would be either higher or lower than the best fit sphere, and it's built off of two different spheres, one being that scleral kind of big ball, and then the bi-elevation, the other measurement is corneal shape, because those are two totally different curves often. And so that's why we do the bisphere elevation map with the two different areas to give the most accurate elevation that's the most useful for contact lens fitting. Now, I want to show you, this is really cool. So this is a quick eye ID. So when we take a look at a map, a bisphere map like this from the ESP, we're very used to looking at, let's just say on a corneal topographer, and it's the exact same thing with the ESP corneal topography as well, but there's a characteristic pattern that we would see using axial power maps, for example, on a Placido ring topographer, for example. So, if we think about our characteristic keratoconus eye, we see that kind of hot spot red in the bottom and the inferior for where the cone could be. We're used to seeing a certain pattern. And that's why this is a really, really cool figure that gives us an idea to kind of also show some of these characteristic patterns. And we call it kind of the quick eye ID, just to show examples to kind of orient you to the similar sort of thing of what exactly the maps look like using the ESP. And you'll see that they're actually very, very similar. Patterns are patterns. For example, you can see on the top, these are, ectatic conditions and conditions, pingueculas that have an elevation or some kind of lump or bump on the eye. Across the top, pellucid is the first example where you can see that hot spot or that curve being a little bit different in the inferior. The central cone post-LASIK looks completely different, and then a pinguecula viewed here on the far right. Now, scleral toricity is really cool because studies have shown that it really is not something that we correlate between cornea and sclera that is kind of carries on. In fact, sometimes we can have corneal shape that's completely different than the scleral shape. There are some patients that it carries across. And again, that's also kind of another reason why it is very, very important to really get a good look at ocular shape and comprehensive ocular shape before making decisions, on fitting a lens, because in some cases, just because we have corneal astigmatism, for example, does not mean when fitting a scleral, we need a toric haptic. In a lot of cases, it does. But the cool thing that we've learned from images like this and from, study banks with many, many patients that we've scanned using profilometry devices to get data on what ocular shape really looks like on average for most people, is that, sometimes the data just doesn't come across from cornea to scleral. Here's an example on the bottom of a scleral toricity. We have with the rule, against the rule, oblique, and then a very irregular shape. And you can see we have those kind of standard toric patterns, and then all the way over to irregular. And we can have very spherical scleras as well. So this is kind of a cool figure just to kind of see how easy it is to see the different variations in corneal shape and scleral shape all in one picture. Now, this is another map that we use in the ESP, and it's an awesome map for a lot of different reasons. This is a tangent angle map. And basically what it does is it gives just an additional way to analyze the ocular surface. And it's very, very good for detecting kind of an instantaneous kind of curvature map that gives us, in particular, I'll use this map a lot for looking to see, for example, if a patient has an impression ring. This is an example of a patient that has had a scleral lens on for, however many days, didn't take many days off, maybe took the lens in and took it off in the clinic. And what you can see here, you can see kind of a half ring if you look toward the kind of inferior right-hand side where there's kind of a moon shape of yellow turning into red. And it just doesn't have that smooth transition of color, is where we have kind of a bunching of tissue or kind of an impression ring. And this shows us, this map is very useful for seeing if we're still getting an impression ring from a patient that we're refitting that has been wearing a scleral lens. And I want to share a little more about this. Just throw in a case really quickly here. There's a case in the clinic this week. A patient of mine, a 49-year-old male, keratoconus. He has a big pinguecula that's viewed. You can kind of see it in the picture. And he, very high prescription with his keratoconus, came in to be refit in the right eye recently, or asked to be refit. We kind of made the team decision that we're going to put him in something different because he had a lens that was performing fairly well on the right eye, commercially kind of fit lens, non-impression driven. But again, we have wonderful options on the market for fitting scleral lenses that are of all different fitting styles. In this case, on his left eye, he has graft, more compromised eye. So had already been fit in an impression lens that more closely matched that eye shape. And he wanted impression on both sides because he felt like he really liked the way that the lens handled and he liked the fit of it the most and yada, yada, yada. He was ready to have the lenses match for the optic as well for the multifocal. So we brought him in and brought him in to fit him with an impression and a profilometry image. Often what I'll do with a lens design, if I'm going with a lens that's a free form that has an option for an impression versus a digital scan, I'll often take both. Specifically in this case, it was an iFit lens that, again, whenever we have access to two pieces of data, two is always better than one. And so I will use impressions and scans to compare data and make sure that we're not running into any poor data and kind of look at the big picture using those two different styles, especially patients that travel from out of town. We'll do both. And so in this case, we brought the patient in to get an impression done. And so redid his right eye. He was out of his lens for, we usually say more than 48 hours is kind of the bare minimum. Studies have shown that when we take a patient out of a scleral, it can take, more than 2 days to recover. In fact, that little impression ring that'll last on the eye from scleral lens work can kind of stick around for a long time. And so 48 hours being the bare minimum. And this patient, assured us, yep, been out of my lens for 48 hours. So here's our scan. You can see this is a biosphere elevation map, and very clear on the right-hand side of that picture, that kind of hot spot is definitely where his pinguecula is. It's a raised elevation on the eye. And so, this looks pretty good to me. So we took an impression, we took this ESP scan, sent it into the lab, and I want to kind of go over what the lab said about this scan, just to teach a little bit about how to best use the data. So here's our beautiful scan. Looks like the real estate is good. If I was to pull up the indices, they're fairly good as well. And in this case, what did the lab actually say? We thought it would be kind of a great scan, but the lab rejected this impression and this scan. And the reason why is because the patient still showed up with a little bit of an impression ring in the scan. And, the one mistake I made on this case was looking at just the biosphere scan without pulling out the tangent one, which I can show you here, the tangent angles map. Now, this map is extremely useful. Here it is here with a quad view of what the information we can get from the ESP. Top is actually the scan that we used, and I want to teach you a little bit about what the lab came back to me again in this case. Didn't look carefully enough back at all the scans to really see that there were some flaws in the data collection. So top right is kind of that raw data where I show you the acquisition screen. Below it is a corneal elevation map. To the right of that, bottom right, is going to be our biosphere. And then the most important one is the tangent, and on the right-hand side, blown up larger. And again, this is an example. If I had pulled this map from the ESP, this would have given me the indication not to bother sending the impression in at all and have the patient come back and, take more time out of the lens. And I called the patient, call him out and said, look, are you sure you took 48 hours out of your lens? And of course, not the first time in the clinic. Patients hate taking breaks from their lenses, and it turned out he'd actually only stopped wearing it the night before, which is actually less than 24 hours. And so in this case, the lab was right. We were just going to bring him back for a scan. The lesson here and how to use the data is we would actually pull this tangent map and not trust the patient, but don't trust the patient. They're going to do what they're going to do sometimes. And so we always want to take a look at these maps to do a better job of making sure that our data is nice and clean. Here's an example of digital data. So I wanted to just pop this in here with and without the lens. This is the same patient and what the lab was able to generate, although the data, we decided to bring the patient back, but it really kind of highlights the cool aspects of using digital software to be able to collect data, map out the eye, and we can create empirical lenses based on that data that are actually very, very accurate and true to the shape that we see in the clinic when the lenses come in. Now, I want to share just a little bit about SIMK and like how the eye metrics work here. And so eye metrics kind of short review. This is a review of different information that we get. And so some of the things that we can get that we, normally would take extra time in the chair are, when we're fitting a scleral lens, corneal lens, OrthoK, soft lens, we always need to understand, these metrics, including iris diameter, pupil size. We can take a look at this left-hand image, and it's actually a really cool picture that allows us to digitally take a look at what is the anatomical position of the pupil. Now, there's patients that we have in the clinic sometimes that have failures when we fit them with multifocals, for example, because there can be a mismatch in the location of the anatomical pupil and the visual axis, and then the lens could maybe land in a different spot. So to give you a little bit more information on that note, the pupil, we have learned, it's accepted, and we see this in the clinic and in studies that look at anatomy. Pupil is usually located superior nasal. Contact lenses inherently always almost decenter inferior temporal. And so that sometimes can create a mismatch. And using scans like this, we can really clearly see data and really see kind of exactly what's going on, just to pull hot metrics and things like that from the data to create lenses. Sagittal calculator, of course, this is a mainstay. We use this all the time for sclerals, soft lenses now. And what it does is basically there's a SAG calculator in the unit that accurately will calculate the height of the eye at any given chord. Again, this is, essential to be able to, really, design a lens, especially scleral lenses. And so basically what we do is we can use the height of the SAG at 2 different meridians to create lenses that are custom fit, that are highly, highly accurate. To kind of put this into a nice little figure, there's lots of different ways that we look at chords. So, OrthoK uses chords as well. And so what chord means is it's a kind of a given section of the eye. So say at like an 8mm chord, what is the height of that eye? That would be kind of what you see on the top. Custom soft kind of moves down and scleral moves down. So our typical chord that we'll start looking at as scleral, of course, is going to be a little bit broader. Scleral lenses typically will start the landing of a scleral lens about 1 millimeter past the limbus at least, and we can use sagittal height measurements generated by the ESP to really accurately design lenses as well. Here's an overrefraction calculator, and I just want to highlight that this is kind of another cool feature. The slide's a little bit busy, but it shows a lot of the different customizations that we can do within a lens design to create like a better kind of tear film. So for example, we can play around with parameters within these calculators that are in the software to best predict fit. So for example, we know that if we change a base curve, that's going to affect power because, a steeper or flatter lens would have more plus or minus in the power. And so we can use these to automate it and really kind of empirically calculate changes that we want to make to kind of best determine a lens power to order even after we make modifications within the software. Now, first lens fit is where things get kind of back into the clinic. So that kind of goes through some of the, features of the ESP. And I want to talk just briefly about first lens fit because it's totally awesome. First lens fit basically allows us to take data and move it into lens design. Now, first lens fit algorithms include scleral lenses, OrthoK lenses, soft lenses, hybrids, and GPs. The really cool thing about first lens fit algorithms is that, they play nice with a variety of different manufacturers, and I'll share that with you. But basically, the first fit first lens fit algorithm is kind of the primary point that I use in the clinic so we collect data, we analyze data and kind of look at it. We're going to see what we're dealing with, and we can make decisions about kind of what we're planning to do, pull starting lenses and so forth. Now, the first lens fit algorithm allows kind of an automated, streamlined fitting process where you can select the lab and lens design that you're wanting to work with. So if I'm fitting, a scleral lens, I'm going to select scleral first lens fit, and then from there, there's an option to select whatever manufacturer that you're wanting to work with that's within the software. And the cool thing about ESP, honestly, through, many years of working with, lots of different devices, I would say that we have such a community. And, the really fun thing for me, in particular with the ESP specifically, is just the teamwork. The unit really is an open platform. And so with ESP, there is not just one design that you have to use. If you are a fitter that has a good relationship with, lab, whatever, there's a good chance that there's going to be an option for you to work within the software to also work with the lab of choice. As you can see, this list is huge. So take a minute to kind of peek through this and look to see if your preferred lab, there's chances are, you're already working with one, if not more of these labs. And it just makes it very, very easy because it's a lab neutral device that allows us to kind of reach wide and far when it comes to working with labs that we prefer, and also not always just the same lab, which is kind of nice. And for the labs out there, and for those listening to this too, again, ESP is a very open platform, and the algorithms, the first fit algorithms, are always improving and changing. Lens order system has a direct connection. So I want to just briefly talk about this, and then we'll move into some cases and some other cool things. So here's the last sort of piece. So take a measurement, look at all your data, and after you've selected which lab you want to work with and what your lens design of preferred choice is, each lab has a slightly different flavor of where it will take you to a page that either is just, allows you to play with the software and design lenses yourself, depending on your comfort level with that. You can click and ask for consultation. You can send it straight over and have them email you. There's all kinds of different features, and it really is all kind of independent and sort of customizable to you and to the lab of your choice. I want to take a second to just mention some top tips. So here's 3 top tips. So we're going to break away from going through product stuff because that's very important. I wanted to share that with you, and I want to spend some time at the very end to answer more questions about the ESP specifically. We've got some folks, as you know, Ted and Elaine are here to answer questions, but I want to get into some of the clinical side and share my top tips. 3 things that come to mind for me in the clinic when it comes to working with our lab. So now this is my top tip number 1. And what it is I love using the device for education. And so the education generated that we can, use the tool as a teaching tool. So we love, showing patients when they come into the clinic. Everybody has a story. Everybody has their own unique sort of, history of maybe difficulties that they've had with their vision, or surgeries they've had, or failures with contact lenses, or why they just couldn't be fit with something else. And so the profilometry top tip number 1 in the clinic is we love using it at our office for patient education. We use it in marketing. We use it to be kind of stand out from our competitors. So there's something a little different that we can offer above and beyond just the simple reality of precise measurement before fitting lenses. And so tip number 1, use for education. Tip number 2 I want to mention is measure first, fit second. So I love this when it comes to, any of our measuring tools. We would never dream of, putting a patient on glaucoma medication without measuring pressure first. So it's kind of that sort of analogous to that as well, in that anytime that we're thinking about fitting lens, it's always more effective and efficient to measure first and figure out exactly what we're dealing with before we move into the lens. I mean, you could do it in reverse because that's also a way that you can get to the finish line, but I want to share a case next of a 20-year-old male, advanced keratoconus and high drops. He came to the clinic with failed fits with soft and corneal GP lenses. Here's an example patient. You can see some scans just to show his high drops is kind of cool. You can see it in the picture on the bottom left with a break in Desmais membrane and that little thing flopping in the wind in the posterior cornea. Right side, extremely thin, very ectatic, highly irregular corneal shape. And again, lots of failures. So I want to share this case where this is a patient that we fit in the clinic over a series of different visits. The diagnostic fits lenses to the final lens was 5 lenses. So this I wouldn't say is atypical, honestly, for difficult eyes. We fit from a diagnostic fitting set, which is a very, very correct and effective way to get, scleral lenses fit. But I want to just kind of circle back to the reality of kind of what could have been had we measured first and then fit the lens second, rather than start putting lenses on and change. Here is our first fit. So I went back after the fact on this patient and scanned his eye, looked at he actually in the beginning when he was fit we didn't have ESPs on file. And he was working with a resident, which is a great opportunity for a new doctor to really kind of dig into what does a lens look like on the eye? How do we evaluate with a slit lamp? Because all of those things are absolutely essential. I would never fit a lens empirically and dream, ever that we would be doing away with the slit lamp or not having, proper evaluation and skills when, making changes. But had we used our first lens fit, this is in reverse using a first lens fit algorithm. The predicted lens here is a lot closer to the final lens than what we started off with. And I do believe that had we started in this direction, it would have definitely saved chair time. And, the other thing that's really kind of cool about had we taken more time with this patient to really evaluate data. Now, this is the biosphere elevation side profile, and it doesn't, it's plain as day how steeply ectatic this eye is. So in the first lens that we chose, we didn't have any decrease in limbal clearance. We just went with getting the first lens in. Had we more carefully evaluated this shape prior to putting a lens on the eye, my first move would have been to decrease limbal clearance, because we know how steep and proud that central cornea is, and a lens on top of it is going to have excessive space at the limbus. That right there would skip a step. I wanted to also just show the corneal elevation shape here. If we kind of take a peek at our biosphere, again, we can get data that is very accurate for the point that's going to contact that eye first, and the elevation drops away very suddenly on this patient. And so that tells me that that blue area underneath a contact lens that's more even in the kind of across that anterior shape is going to really have a big gap where the eye drops off. And again, in hindsight, looking from reverse, in this case, had we looked at these scans a little more carefully, use the first lens fit, very unlikely that we would have gone to 5 lenses. So just kind of a cool example. Now, tip number 3 is also just kind of on this note where you see the corneal topographer is remember that profilometry is for cornea too. So there are cases that with sometimes it's very hard to get data, especially on corneal graphs, to get accurate data with certain systems that, it's hard sometimes. These are maps on graphs that were just a little trickier with this particular type of topographer. And then with the profilometry, you can see that the same patient, we're able to image a lot easier. We're going to go through some cases now. So we've got about 15 minutes to go through these, and I want to make sure that there's a little bit of time for questions. These are not difficult cases. These are cases to really highlight the kind of breadth of what the ESP is capable of, what profilometry is capable of in terms of how it helps us to fit contact lenses. And this, one of the cool things that I've really kind of dug into more in the past, probably, a couple of years, is really sclerals is what we kind of thought of initially when we look at comprehensive ocular shape with these tools that go beyond the cornea. But the reality is that we really should be using comprehensive ocular surface topography for really any contact lens design. And the cool thing about, a unit like this is that it really has the capability to fit a variety of different things in the clinic. So that's why, we lean on it a lot in the clinic and measure every single contact lens patient, no matter what they're having. We don't run ESP on a standard eye exam that wears, regular contact lenses, but every specialty lens fit in our clinic, we'll run an ESP on. And again, the reason why, understand ocular shape, figure out what we're dealing with, pick our lens, and kind of figure out how can we design something a little bit more effectively and efficiently. Now, let's talk first about scleral lenses. So here's a case that just kind of highlights, an example of how we would use the profile map in the clinic to get a really good kind of understanding of what that ocular shape looks like, so that we can choose the right lens design, and how we can also, figure out not only what lens design is, but say if we're going to fit this patient, we're talking sclerals. This allows us to determine if we need to be fitting a spherical haptic, if we need to be fitting a toric, quadrant, or irregular. And so it's a really cool map that allows us to really take a look at what the scleral profile looks like so that we're able to best choose our kind of starting lens. Now, here's a patient, a 38-year-old male in our clinic, mild keratoconus, and this case really kind of highlights and discusses the way that we use profilometry to understand sag differences from the sagittal height calculator for fitting sclerals. So we're going to discuss, there's many cases where there's a little bit of toricity already at the limbus, and now this case really highlights the ability of using software to predict whether we need, for example, a freeform, or if we have a capability of fitting an eye with a lens that can accommodate different sagittal heights, different landing shapes, and so forth. So again, 38-year-old male, eye health is unremarkable. Mild keratoconus has already been cross-linked. Now, this is the patient's map of showing a bisphere elevation map. And the cool thing about looking at this is in the software, we can take several different chords. So if we were to look at the height of the eye at, say, a smaller chord around where the edge of the cornea might fall. So in this case, we chose like a 13.8. And again, just to kind of go back to what we're thinking about when we're fitting a scleral lens on the eye. So the image that you're looking at on this left-hand side, let's just focus on one eye at a time to really explain this well. And if I picture where I want a scleral lens to land, I want the lens to vault over the entire cornea, and I want it to land a little bit outside the limbus so that we have full limbal clearance. Usually that's about 1 millimeter wider than the visible iris diameter, because that's kind of where that limbal transition zone lands. And so in this case, we chose a 13.8-ish chord because that would be about 1 millimeter, a little bit more wider than what the corneal diameter is, to kind of picture in your mind exactly where that lens will start to land. That first landing point, or that first touch point on the eye, can be affected by elevation height. So an eye that's perfectly symmetrical right around the limbus is going to be just fine with a lens shape that lands equally all around that space. Now, what the software allows us to assess is, are there differences in the landing from that space where the lens lands all the way out to the landing zone on the sclera at a broader chord? And it also allows us to take different cross sections and look at the height of the eye, not only just in one meridian and kind of assume it's the same all the way around, which it isn't. It allows us to also take chords at different meridians, so that then we can picture in our minds, what is the shape of the eye at the limbus? Because the lens has to start landing there. What is the shape of the eye at the landing? Because the lens is also landing on the sclera there. And what that allows us to do is, for example, in this case, decide we want to have a bitoric, or almost kind of like a shape that lands with different heights, not only just at the landing, like a toric haptic, but also if the eye is asymmetrical within that first landing at a smaller chord. So in this case, we start off by looking at the chord at about 13.8 or 14 out to 16. And the height of the eye definitely varies. Of course, that makes sense that there's going to be a different height at a different chord, because the broader we go out, the higher elevation an eye would be. Now, what we do is we take the data and we can look at where the toricity lands. And so we can further digest the information in the map to really allow an algorithm, or you can actually click on it yourself to kind of click on the data to look at the height at those different locations to best determine if you want a lens to have a haptic that puts all of the toricity of that eye in the landing, or if the landing around the limbus is a little bit toric too, perhaps we would want to put a little bit of toricity or a little bit of a shape difference in 2 different meridians at the corneal junction out to the limbus as well. So in this case, we use the first fit kind of algorithm. It's a ZenLens bi-elevation design, and pulled data at those different heights, at those different chords to select a bi-elevation lens. And in this case, again, first lens was really great. It looked awesome on the eye. This is some data that just showed kind of what the lens looked like on the first round. You see this is an OCT scan on the top left showing corneal clearance with landing around the edges that matches the anterior segment photography on the bottom left. and lens really was pretty awesome on the first round. We use profilometry as well to fit OrthoK when we're in the clinic as well. So just remember that profilometry is not just for fitting sclerals. Algorithms have been really getting better and better when it comes to fitting OrthoK. In fact, there's a number of different vendors and manufacturers that work with ESP algorithms to fit OrthoK, and that kind of makes the unit useful as kind of a one-stop shop. If you don't already have another corneal topographer, and you're considering it, you could use the one unit for all things, for scleral and corneal design of corneal GPs and also OrthoK. So here's a case highlighting an OrthoK patient. This is a 27-year-old female with dry eyes. So she's a kind of a patient that was not successful in soft lenses. And we know that adults can wear OrthoK too. And so sometimes we fit patients with OrthoK just because they're not particularly successful in soft lenses. In her case, she's got very bad dry eye. Here's her refraction on the bottom left. So pretty decent range for OrthoK. So she's within that kind of happy zone of not having too much corneal astigmatism. And I wanted to just kind of show her bisphere elevation map just to kind of cut across to really highlight what the maps look like. Here we have comprehensive ocular shape, but when we kind of pull it in a little bit, we can take a look at her corneal shape. And from this map, OrthoK lenses can be designed using algorithms that are based on corneal elevation as well. Now, this is the next map that we use. And so that first image is set as a baseline, and that is used for later for differential maps. So whenever we fit OrthoK lenses, the primary maps that we use would be kind of like a baseline, and then what happens to the eye after treatment. So we'll put those images side by side and take a difference display map of them. And so the very first map is our baseline, which we set as that. Now, our first fit algorithm in this case was a Paragon CRT. And so using the digital software, no different than any other algorithm that's out there for empirical design for OrthoK with other manufacturers and topographers. You can select, kind of put in your starting refraction, astigmatism, and choose lens design. The device can create a digital simulation of what the lens fit will look like. And then, again, ordering the lens can be, you can pull the data, order, however you normally would order, but also using a first fit lens algorithm, click a button and order the lens through your manufacturer. And in this case, again, just to kind of highlight what the lens looked like, just kind of short and sweet. This is the lens on the eye. It's very beautiful. Now, curvature difference maps, this is what they look like. So we are used to looking at these maps when we fit OrthoK, and it's, again, no different, just taking that kind of baseline versus the treated eye and creating an curvature difference display map. Now, it's important to remember with the ESP that this is all elevation based. And so the color scheme, depending on how you set it, can look different, but you can see that this looks very much like we would normally see with OrthoK. And then again, the tangential curvature, again, being more of an instantaneous kind of position map as well on the eye. Now, the last two profiles we're going to move into are just very briefly, I want to show you some cool cases just with soft lenses. Custom soft is really something that profilometry is really a cool asset when fitting custom soft lenses, because when we build custom soft lenses, we're often building lenses or choosing lenses based on the base curve and power. The reality is that there's also important, and if you have kind of the insight and ability to look at the sagittal height of the eye, that can also be responsible for largely success in comfort and fit when it comes to fitting soft contact lenses. In fact, there are actually studies that have come out looking at what is the sagittal height of all of our commercially available lenses. And there are some patients that we've had in the clinic that for whatever reason are not comfortable in a certain lens. And when we go back and compare an ESP seg at that lens cord versus the actual seg of the lens, if there's a mismatch there, that can affect overall success and comfort with the lens. Now, here's just a kind of a cool case that, we presented earlier this year at the GSLS, and it is a case of a patient who is 39 years old. Her history is remarkable for having PRK, so her ocular shape is very flat on the top. What that does with some patients, and many patients, in fact, results in kind of a mismatch from a commercially available sort of prolate contact lens shape that's round with their tabletop eye shape. Patients that have had ocular refractive surgery sometimes run into issues where they're not able to successfully wear conventional lenses because they have a peripheral base curve that's steeper, and then their central flat base curve creates two different shapes. Symptoms of that really are just fluctuating vision, lenses that move around too much, vision that just is not adequate. And so in this case, there's a patient that had declined a hard lens fit, and we were able to create a custom soft lens. And just to give you, this is a diagram on the left that kind of shows what I'm talking about, where if we have two curves, an 8.5, too steep in the center, too tight on the sides. A 9.0 below fluctuates because it's too flat in the center where the sides are kind of flopping in the wind. Now, what we can do with ocular surface profilometry is take sagittal height measurements to better fit an eye with custom lenses, or choosing lenses that are commercially available, knowing that we have guides that tell us exactly how high those lenses are. So in this case, we used sagittal height measurements along with, refractive error, et cetera, to design dual base curve lenses. So these are all kind of early designs that are, still in beta testing phase, but very, very cool stuff out there that allowed us to use a sagittal height to create a lens that was a better fit than anything that was commercially available, and create a device or a lens that the patient was able to wear successfully. Now, finally, we have GP fits, and these are probably one of my more exciting things that I'm most excited about in the clinic lately, with our profilometers, just because it's just so cool to see our software really developing, kind of, again, very similar to how we've seen sclerals progress. We have never forget about the corneal GP. And we can also use that data that we generate with ESP to build corneal GP lenses very quickly, very easily as well. 56-year-old, high prescription, presbyopic, so he needs a reading ad, and his history was just kind of poor fits in the past. Not to say we wouldn't be able to, fiddle around with it and get, effective results, but nonetheless, we'd had providers trying multiple different styles of lenses in the past, with very little success. So we thought we'd take a crack at it just to see if we could empirically design something that perhaps would be a little bit better fit when he was due for new lenses. ESP corneal topography, again, dialing right in, you can see the ocular shape based on elevation. In this case, just using the algorithms, we were able to create using TrueCone, which is a design from Trueform, lenses that were very comfortable. And again, just not because these are difficult cases in any way. The whole purpose in showing these is really just to highlight the kind of breadth of different things that we can do using profilometry, and that there's really the possibilities are endless within a clinic that is wanting to use tools to create multiple different devices or multiple different modalities. Profilometry is one that really has come a very long way, and that we can actually pull effectively data and today turn it into lenses that really are actually pretty awesome. And there's a lens on the eye. So recap, in summary, just a recap of the eye surface profiler really creates kind of the possibility to analyze and adapt and identify problem spots. It allows us to go back in fits that we have going that we're having problems in to identify, and it's doesn't happen infrequently where there could be a patient in the clinic that's struggling with a certain aspect of their fit, maybe a patient that's been in lenses for a long time. And if we pull them out and take a really comprehensive look using profilometer at what the actual shape of that eye is, often it can be used to troubleshoot and also to prevent those issues if we were to measure first and fit second. In summary, it's a very open platform unit, which is really great, where there are lens fit algorithms, external software options, tons of different labs that are compatible and play nice with the profiler. And its options include all different modalities, hard lenses, soft lenses, small, large, all of the above. And as a recap, top 3 tips: use profilometry to educate, measure first fit second, and also that profilometry is for the cornea too. So I want to just thank you at the end of this clinic day for me, and also for those of you out there that are finishing clinic with your families, whatever it is that you're up to. Thank you so much for taking the time. My email's here if anybody has any questions, and we will stay on for any questions that have come up in the chat.
Thank you very much, Sheila. That was just terrific. And we do have a couple questions in the chat area. So one is, dry eye patients have short TBUT.
T-bats, yep.
Yeah. Will it affect the ESP measurement? And then second part of that is, do you use LA to take the ESP measurement?
Yeah, so dry eye absolutely can impact it for sure. I do find that honestly though, with, and that's with any topographer, dry eye and ocular surface can impact any measurements that we take in the clinic that measure the anterior eye. The best thing that we have found that actually there's very, very few patients that we cannot get a scan on because of dry eye, because of the hydration step at the beginning. And in those cases too, I find sometimes patients with really, really dry eye that are very sensitive to holding the eyes open or whatever, we do sometimes use a numbing agent as well. And that I think that also softens just a little bit so that we do have our lubricating drop kind of stay on the eye. And to be honest, there's not very many patients that we can't get good data. Now, when we analyze data, you do have to be cognizant of that. And that's not just with dry eye patients that don't have dry eye sometimes, and not just with the ESP, but with other units that measure anterior eye shape, can also have defects because the tear film breaks up. And that's where it's really, really important to go back and look at the quality of what you're taking, and just make sure that, if the indices show that you're getting a lot of tear breakup or we're not getting enough coverage, you just have to go back and take another image.
And by the way, you answered the question because LA stood for local anesthesia.
Okay, yeah. So, and technically, so it really kind of depends. So I'm going to get into that. I'll dive in a little more because that's what this is for to have a forum. We want to share what we know with each other. I would say in our training, with the ESP, I don't know that we're always asking practitioners to use numbing because it's not really necessary, honestly. A lot of patients do just fine with no numbing. I do find though, for some patients that are particularly really sensitive, either from having discomfort or their eyes just water, and that kind of fluid flow affects the quality of the images. The numbing will help to kind of help with reflex tearing and just allow you to get the images that you need. But there's a lot of patients we don't use numbing on. In fact, a lot of patients we don't.
Right, right. Yeah, I would say that it seems like around 70 to 80% of our ESP users use proparacaine a fair amount of the time. Since we're talking about topography, could you talk a little bit more about the difference between, in your mind, the difference between using curvature versus height data for lenses?
Yeah, so curvature can go in any direction. And so curvature can be like a little bit less useful when you're looking at like the elevation is super, super helpful when you're considering the physical structure. What is the first point or the height that you're going to actually have the plastic come into contact with first? And so that's where elevation is actually in many ways more useful if you're thinking what kind of data map to use, and that's across all topographers for contact lens design. It's actually the elevation that we're really looking at to figure out what the best shape of lens that we want to use should be.
Okay. Yeah, because a lot of people initially get a little confused because we're using height data as opposed to curvature data, and they're making that conversion from using a topographer every day to the ESP.
Yes.
Okay.
ESP is elevation driven. And so you really just have to think about what is that physical structure. It's almost like a geographical map in your mind. And it's, it's just a little bit of a different way of kind of thinking about the data.
And it seems like a lot of the new lenses that are coming out, especially freeform lenses, are all based on height data.
Correct.
Okay.
And it's not unique to the ESP. All topographers use elevation data as well.
Mhm.
It just depends on like what kind of a screen you're looking at. Whereas, so for example, I think one thing that some practitioners will kind of look twice at initially is, that curvature power map is, I think, what we're talking about as well with other devices. We don't look at the data in that same way. But we can understand how the data, it's just a little bit of a different way of looking at it.
Okay. Okay. And then when you're using the ESP for, let's say, whether it's OrthoK or it could be RGP, um, I guess you got your technicians pretty well trained to know that they don't have to hold the eyelids that wide open. It's a different kind of scan for that particular kind of patient.
Yeah, we still do it the same almost every single time because it's really not hard to do. And so to be honest, like with the OrthoK or with if we're, for example, fitting for a corneal GP, any scan that we do, we attempt to move the lids out of the way as to the best of our ability. It should never be painful. It should never be pulling. But it is true that you do not need to have the lids open all the way to the sclera for OrthoK, so it makes it just a little bit easier.
Okay.
Mhm.
Okay, well, that's all the questions and comments I think that we have. Let me scroll through there. Yeah, that's it for now. Um, Again, I'd like to thank everybody for attending, for paying good attention, and the questions that were given to us to answer. And Dr. Morrison, terrific presentation, real great detail on the ESP, and then super cases to review actually how it works in the real world. Thank you very much.
Thank you for having me.